الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Hazardous exposures for healthcare workers and their clinical manifestations and prevention by Professor Mahmoud Hani Sulaiman. Workers in healthcare. It is a long list. Every job exposed to some of the hazardous exposures. So we have clinical jobs, nursing, clinical support, facility support, and office-based. All these may be exposed to some of the hazards present at healthcare facilities. Occupational hazards in healthcare facilities. It is either biological, chemical, physical, psychosocial, ergonomic, violence, accident, lifestyle hazards. So the hazards are biological, chemical, physical, psychosocial, ergonomic, violence, accident, and lifestyle hazards. Main biological hazards in healthcare facilities. It will be discussed in details. Blood-borne pathogens, methicillin-resistant staph aureus, MRSA, TB, and other airborne diseases, latex, natural latex rubber, medical waste. Occupational illness acquired through contact with humans. The healthcare workers are exposed to all these infections. Percutaneous inoculation, airborne transmission, respiratory droplets, fecal-oral transmission, and direct contact. Percutaneous inoculation, airborne transmission, respiratory droplets, fecal-oral transmission, and direct contact. And before, in front of each of these methods, the major methods for prevention are listed. Please read it carefully and use it in your hospital or healthcare facility. Again, every entity of healthcare workers are exposed to some of these diseases. So the healthcare workers, the hospital dietary workers, the lab workers, the medical doctors, the microbiologists, the vets who are present in the healthcare facility are exposed to these infectious pathogens. Please read it and use it in your healthcare facility. Work restrictions and their duration for healthcare workers with infectious disease. I began with this to see that these infections are limiting the work of the healthcare workers. The disease requiring no patient contact, infectious conjunctivitis, acute diarrhea with symptoms, group A streptococcal disease, hepatitis A, herpes simplex infection on the hands, active measles infection. And please note that when a star is present, the food handlers should be excluded from work till being free. This is the first table of disease requiring no patient contact. Again, the disease requiring no patient contact, post-exposure to measles, active mumps, post-exposure to mumps, active pertussis, active rubella, post-exposure to rubella, scabies, staph aureus infection of skin, group A streptococcal infection, active tuberculosis, active varicella, post-exposure to varicella. All this again need no contact with patient, and the duration to each of no contact is present in front of each disease. Please read it and use it in your hospital to make control of the infection. Work restrictions for healthcare workers with infectious disease continued. Disease requiring partial work restrictions. Acute febrile viral respiratory infection, diarrhea caused by enteroviral infection, hepatitis B E antigen positive, Orofacial herpes simplex, human immunodeficiency virus, Staph aureus respiratory infections, active varicella zoster. Bloodborne infections for healthcare workers. Exposure prevention for blood-borne infections, universal precautions, annual training, engineering controls, and provision of hepatitis B vaccine to exposed healthcare workers. Standard precautions include use of gloves, gowns, facial protection where exposure to blood or body fluids may occur. They also include basic elements of infection control as hand washing and proper sharps disposal. Regard all blood and body fluids except sweat are potentially infectious regardless of infectious status of the patient. HIV. Exposed healthcare workers given antiretroviral prophylactic medication, zidovudine, and had less HIV. Prophylaxis can prevent HIV but not always effective. Several seroconversions occur despite of prophylaxis due to viral resistance, late initiation of therapy, inadequate length of therapy, or an large dose of the virus. Healthcare workers exposed to HIV should begin prophylaxis as soon as possible following exposure to a certain source patient infectious status, and to monitor side effects and do serological results in exposed. Hepatitis B. Percutaneous exposure to HBV infected blood will lead to risk of about 6% if source is E antigen negative, and to about 1/3 of cases if source E antigen positive. Increased risk will lead to higher rates of viral replication among E antigen positive individuals. Viral titers vary considerably, may reach 1 billion virions per milli of blood or serous fluid. 1 billion virions per 1 milli. Titers are lower in saliva, semen, and vaginal secretions. In contrast to HIV and HCV, HBV is resistant to drying, ambient temperatures, simple detergents, and alcohol, and may survive on surface for 1 week. So, contaminated sharp objects may pose a threat to healthcare workers for several days following last contact with the source patient. Hepatitis B continued. Incubation period from 1 week to 3 weeks, and less than 50% of who become infected with HBV manifest acute symptoms, acute illness, several weeks, malaise, jaundice, and anorexia. Fulminant hepatitis develop in about 1% of patients, chronic infection in 5% of patients with hepatitis B surface antigenemia. In non-chronic patients, HBV surface antibody develops as surface antigen levels 4. IgM core antibodies to hepatitis indicate current infection, while IgG core antibodies are a marker of past infection. E antigen is a marker of viral replication, and the case can be infectious. Cirrhosis develops in about 1/3 of individuals with chronic hepatitis B, 20% of whom will develop hepatocellular carcinoma. Hepatitis B vaccine will lead to immunity in more than 90% of those who receive 3 doses. Immunity lasts for at least 12 years. Currently, no recommendation for periodic booster dose, nor non-responders to vaccine must given 3 doses again. Hepatitis B immune globulin should be given as soon as possible of the needle stick, but effective when given 7 days after exposure. So it is better to be given 7 days after exposure. It is 75% effective in preventing HBV infection in those without vaccine-induced protection. The single most effective step to prevent hepatitis B infection among healthcare workers is vaccination before the needle stick. Hepatitis C. Among healthcare worker, prevalence equal to general population. Following percutaneous exposure to infected blood, risk of seroconversion in healthcare workers may reach 10%, average about 2%. Infection after mucocutaneous exposure is less common. HCV viral titers are low compared to HPV, HCC, not in urine, feces, or vaginal fluids. In incubation period 2 to 24 weeks, the average is about 7 weeks. Antibodies detected in 6 weeks of infection and persist regardless of whether virus is actively replicating. Continued hepatitis C. Chronic hepatitis develops in 80% of them. There is no known neutralizing antibody to HCV and no vaccine is available. Administration of immune globulin has not been shown to be effective. Several studies showed efficacy of interferon alpha to be an effective treatment, and there are other treatments. Healthcare worker exposed percutaneously or mucocutaneously to HCC should have hepatitis C antibody checked at 0, 6, 12, and 24 weeks after exposure. Seroconverters must do PCR to detect viral replication. Refer to hepatologist to consider early treatment with interferon and ribavirin and other drugs. At present, the 3 direct-acting all-oral combination drug therapy recommended for HCV genotypes 1A and 1B and genotype 4 include ledipasvir and sofosbuvir, which is called Harvonil, and Vicarapac and Zibatier. For people with compensated cirrhosis or who failed the previous antiviral therapy, treatment duration may vary from 12 to 24 weeks, depending on treatment regimen used and patient's previous receiving of HCV antiviral therapy. Together, these regimens offer hope for cure without significant adverse effects for a large population of adult and ultimately pediatric patients with HCV infection. At current time, several of oral anti-HCV regimens are being evaluated in clinical trials among children. The aim of treatment of HCV is to eradicate HCV RNA from serum. Please print this and read it. Management of needle stick injury and exposure to blood or body fluids. Personal management of needle stick. If a staff member has parenteral or mucous membrane or cutaneous exposure of non-intact skin involving blood, action outlined below should be taken. Immediate action: if skin penetrated, wash the area with soap and water. If blood gets on skin, irrespective of whether there are cuts or abrasions, wash all with soap and water. If eye is contaminated, rinse the area gently but thoroughly with water or normal saline while the eyes are open. If blood gets in mouth, spit it out and then rinse the mouth with water several times. Report to supervisor or occupational health officer. Complete an accident report form and include date and time of exposure, how the incident occurred, name of the source individual. If known, incidents that did not occur at work should be reported to a doctor or the accident and emergency department at the nearest hospital. If a needle syringe was involved, place it in a rigid walled container as a lunchbox. Take it with you to the doctor. Note: do not cover needle because of risk of further injury. If source of exposure has HIV, HPV, or HCV positive, the affected person immediately evaluated by a physician. with experience in treatment of these infections. The source patient should be tested for HIV antibody, hepatitis B surface antigen, hepatitis C antibody. Blood samples should be collected as soon as possible after incident and processed urgently. Source HBV positive is exposed persons vaccinated. If vaccinated, take blood test anti-HBs to confirm immunity is maintained, i.e. more than 10 international units per liter. If not vaccinated for HBV, take blood for anti-HBC, anti-HBs surface antigen, and hepatitis B surface antigen that is available in your local lab to determine previous infection. These tests indicate the status of exposed. If the exposed person was previously infected, no further action is required. If affected person not infected with HB and negative for anti-HB surface antigen or has non-protective antibody levels less than 10 international unit, hepatitis B immune globulin within 48 hours of injury. Hepatitis B immunoglobulin within 48 hours of injury. When the source individual is hepatitis B surface antigen positive, the source individual is unknown, the results of tests on source individual and affected person are unavailable within 48 hours. Persons for hepatitis B immune globulin should begin vaccine at same time. 3 vaccinations at 0, 1, and 6 months is required. When affected person is immune, that is to say anti-hepatitis B surface positive, check antibody levels or give booster vaccine if the previous course was completed more than 5 years ago. Source anti-HCV positive. After needle stick, if the source is positive for anti-HCV, so risks and some mechanism of HCV transmission is healthcare worker not established. But thorough watching as for HIV and HBV at the time of injury, there is no method that can alter the likelihood of transmission. Reason for following up affected persons are to ascertain whether HCV infection occurs and to provide treatment and support. Affected persons should be tested for anti-HCV at 0, 3, 6 months. Follow-up should be undertaken by specialists with knowledge of HCV infection. Source, if the source is unknown, reasonable efforts should be made to identify source persons or series, because the follow-up will depend on type of exposure, likelihood of source being positive or for a blood pathogen, prevalence of HIV, HBV, and HCV in the community from which the instrument or needle comes. Follow-up also determines risk of tetanus. The following may be needed: tetanus immunoglobulin, course of adult diphtheria and tetanus, ADT or ADT booster. Human immunodeficiency virus. If source individual is positive for HIV antibody or source is unknown, affected person given advice. Also inform him about risk of transmission, which equals 0.3% if source is HIV positive. Informed consent should be obtained for baseline HIV serology as soon as possible after exposure. An initial positive result indicate that transmission was prior to exposure. Affected initially positive person retested at 3 weeks and 3 months after exposure for HIV antibody. When source individual is HIV positive, post-exposure prophylaxis with zidovudine, known as AZT, given to affected person. Balance between risk of AZT and benefit of it in a pregnant woman who had a significant exposure. Prophylaxis begin only after informing affected persons about absence of data on efficacy, toxicity, and safety of AZT for this purpose. Prophylactic AZT should be free to affected person. Treatment begin as soon as possible after exposure, preferably within 2 hours. Dose of zidovudine 200 mg orally 5 per day or 250 mg 4 times daily for 6 weeks. So 200 mg 5 times per day or 250 gram 4 times in 1 day for 6 weeks. Doctors should emphasize importance of strict compliance with treatment. They should describe the potential side effects and the appropriate course of action if these are experienced. Note: affected person followed up for any fever within 3 months after exposure, particularly fever, rash, lymphadenopathy equal HIV. During these 3 months, do not donate blood, protect sexual partners, avoid pregnancy, consider worker practices for healthcare workers. Infected healthcare workers. Since onset of AIDS epidemic, there was 2 cases in which healthcare workers transmitted HIV to patients. Those performing exposure-prone procedures pose a small risk for transmitting HB or HIV. Exposure-prone procedures equal needle tip with digitally palpated in a body cavity or healthcare worker fingers and a needle or sharp object simultaneously present in a poorly visualized or highly confined anatomic site. Healthcare workers having HIV or HBV are instructed not to perform exposure-prone procedures. Accumulated evidence lead to very little support for exclusion of HIV positive or hepatitis C positive surgeons. Greater hazard still exists among HB infected surgeons with E antigen positive. Tuberculosis risk to healthcare worker increased in 1980s due to emergence of multi-drug resistant TB. More recently, multi-drug resistant TB fallen with 1% of healthcare workers remain at risk. Guidelines address early identification of infectious patients, engineering control to decrease spread of TB bacilli within a medical facility, use of PPDs, and medical surveillance among healthcare workers. These are the steps for screening for healthcare workers for TB done for them at the beginning of their work in a hospital or healthcare facility. Please print it and use it in your clinic. TB and air disease. Routine tuberculin skin testing for healthcare workers. Positive healthcare workers evaluated for TB. Environmental controls should be done. General ventilation, natural and artificial, or room air cleaners, filters, or ultraviolet germicidal irradiation. Enclosed, ventilated, and filtered booth for cough-inducing and aerosol-generating procedures as sputum induction and inhalation therapy. Influenza, measles, rhinovirus, varicella, and severe acute respiratory syndrome are among many other microorganisms which can be transmitted to healthcare workers by airborne route. Respirators are the last line of defense. N95 respirators are the best. Examples are anthrax, tuberculosis in high-risk situations, monkeypox, MERS, aerosol-generating procedures for seasonal influenza, viral hemorrhagic fever, and smallpox. Strategies to identify potential infectious patients: examine HIV-infected homeless present persons for endemic countries of TB, residents of long-term care facilities, and IV drug users. When patients identified and isolated, effectiveness of engineering controls must be done good. For potential infectious patients placed in a negative pressure isolation, work practice control include respiratory isolation, PPDs, and decreased diagnosis and therapeutic procedures to negative pressure isolation settings. Again, PPD as N95 is very good. Medical surveillance of healthcare workers with tuberculin skin testing must be done. Healthcare workers with negative tuberculin should be tested at time of hire. Healthcare workers without TB testing in previous year examined by two-step test. Recommended frequency of ongoing testing is based on a risk assessment. Healthcare workers with documented positive tuberculin test should not be retested and require only regular monitoring of symptoms suggestive of active TB and other documentation done as X-ray, and give prophylactic treatment if the tuberculin is more than 10 millimeters. Methicillin-resistant Staphylococcus aureus, a human pathogen which leads to a wide range of infection from mild skin and soft tissue infection to severe blood infection. MRSA is a multi-drug resistant organism. MRSA colonization seen in about 5% of healthcare workers, with 5% of them being symptomatic. A person can get MRSA by contact with their own nasal bacteria, contact with an infected person's sore, or by contact with carrier who is colonized. Hands are the most important means to transmit infection. Prevention of MRSA using contact precautions, proper hand hygiene, recognition of previously colonized and infected patients, rapid reports of lab results, and training of healthcare workers. This is a picture of a microbiologist use a biological safety cabin to prevent her exposure to harmful bacteria. This must be done in every lab. Infection control and immunizations for healthcare workers. An effective infection control program is essential to minimize infectious disease spread within a medical setting. Patients are at risk from infectious healthcare workers. Prompt assessment of patients and healthcare workers for signs or symptoms of infectious disease are necessary to ensure proper disease containment or use of personal protective equipment. Medical center facility design was shown to directly affect spread of infection. Primary design and renovation of medical centers should include consideration of modern techniques of engineering controls, i.e. ventilation, selection of finishes for surfaces, flooring, privacy, curtains, disposable versus reusable medical equipment. Suggested immunization for healthcare facility employees. Diseases for which immunization is strongly recommended are hepatitis B, measles, mumps, rubella, influenza, and varicella. Diseases for which immunization or immunoprophylaxis may be indicated: TB, typhoid, hepatitis A, pertussis, meningococcal disease. No increased risk among healthcare workers should be current, diphtheria, tetanus. Special circumstances including research and animal labs for rabies, Q fever, polio, vaccinia, others as appropriate for circumstances. Infection by varicella, CMV, cytomegalovirus, and rubella will lead to teratogenic risk for pregnant healthcare worker. Immunization for varicella and rubella prior to pregnancy decrease this risk, though it was previously recommended that women refrain from becoming pregnant for 3 months after receiving vaccine, MMR. Recent recommendations have shortened the waiting period for rubella to about 1 month. Occupational health clinicians play an important role in restriction of healthcare workers exposed to or infected with infectious disease. The following list work restrictions for healthcare workers with infectious disease. It was mentioned before at the beginning of the lecture. Vaccines indicated for healthcare workers to prevent occupational infections. These are the vaccines that the healthcare worker may take to protect him from infection: anthrax, Haemophilus influenza, hepatitis B, influenza vaccine, measles vaccine, meningococcal vaccine, the quadrivalent, mumps live vaccine, pneumococcal vaccine, polio vaccine, rabies vaccine, rubella vaccine, tetanus, DPT or TD, typhoid vaccine, vaccinia smallpox, varicella. This is the described post-exposure prophylaxis for exposure to hepatitis B virus. Please print and use. Described HIV post-exposure prophylaxis for percutaneous injuries. Please print and use. Recommended HIV post-exposure prophylaxis for mucous membrane exposures and non-intact skin. Please print and use. These are elements of standard precautions which must be present in every healthcare facility: hand hygiene, selection of personal protective equipment, respiratory hygiene and cough etiquette, prevention of injury from needles and other sharp objects, cleaning of the patient care environment, linen and waste management, cleaning and disinfection of patient care equipment. Control of medical waste must be done to decrease infection among healthcare workers. Exposure to medical waste can be effectively minimized by treatment and disinfection procedures. This table gives the alternative treatments for medical waste and the advantage and disadvantage of each. Please print and use. What are the chemical exposure among healthcare workers? Here is the list of the most important chemicals in healthcare facilities: ethylene oxide gas, nitrous oxide, halothane and enfluorine, anti-neoplastic cancer drugs like vincristine, dicarbazine, mitomycin, cytosine, arabinoside, and fluorouracil, methyl methacrylate, MMA, ribavirin, formaldehyde, toluene and xylene, gel electrophoresis, acrylamide. Natural latex rubber, NLR, from rubber trees. Pathogenicity due to proteins as havine, chitinase, and B13-glucanase. Manufactures as chemicals, curing agents, and accelerators. Repeated wearing and removal of pre-powdered gloves generates atmosphere heavy with protein-charged cornstarch particles, the main source of exposure to NLR allergens via skin contact and inhalation. Bacteria also grows on the starchy powder. Other medical devices that may contain NLR: blood pressure cuffs, bulb syringes, catheters, dental cofferdam, elastic bandages, electrode pads, endotracheal tubes and airways, enema and syringes, ventriculoperitoneal shunts, finger coats, IV access injection ports, manual resuscitators. There are many devices. In short, population at risk of NLR: healthcare workers wear NLR powdered gloves daily, patients doing multiple surgical procedures, individuals experiencing severe allergy to certain food as banana, kiwi, avocado, nuts, and who are atopic. Health effects due to NLR: allergic or irritant. NLR allergy reactions can be type allergy, type 1 allergy, systemic, generally immediate and possibly life-threatening IgE-mediated allergy. Type 4 allergy, delayed. Type 1 allergy symptoms as rhinitis, conjunctivitis, asthma, urticaria, hives, bronchospasm, facial edema, and even anaphylaxis and death. Irritant reactions affecting most commonly skin: irritant dermatitis, symptoms of dry, itchy, scaly areas of skin that in contact with NLR, aggravated by repeated hand washing, moisture left on hands, or contact with irritating chemicals as alcohol-based hand sensitizer. Control of NLR: converting to powder-free gloves in all healthcare settings in the single most important way for control and prevention. Non-NLR gloves as vinyl nitrile polymer or neoprene pose no risk to NLR sensitive people, should be used for routine tasks. Continued control of NLR, identification of individuals with symptoms of allergy and avoidance of contact, washing hands with mild soap and drying them thoroughly after using NLR gloves, avoiding oil-based creams or lotions. Chemical hazards continued. Cleaning agents, ethylene oxide, formaldehyde, glutaraldehyde, mercury, methyl methacrylate, and surgical smoke. Exposure and control of cleaning agents, inhalation of droplets or vapors and skin must be avoided. Control spray cleaning formulas by wipes or liquid formulas decrease risk of inhalation exposure. Administrative controls decrease occupational exposure, include work shift rotation and employee training, suitable PPE equal appropriate gloves and non-absorbent gowns and eye protection. Main chemical components of cleaning products. Each type of cleaning product is here, and the primary health effect in front of it. Please print and use for choosing the detergent in your hospital. This is the complete of the table present in last slide. Ethylene oxide, gas to sterilize medical equipment that cannot tolerate heat, moisture, and abrasive chemicals. Risk of exposure in central supply who change ethylene oxide cylinders and where sterilization takes place. Exposure is by inhalation. Human carcinogen and reproductive toxin. Acute health effects equal irritation of eyes, upper respiratory symptoms, depression of CNS, headache, and nausea. Formaldehyde, present in hospital lab and autopsy. Exposure by inhalation and skin. It is confirmed human carcinogen. It may lead to dermatitis in contact with small amounts of formaldehyde or formalin. Other effects of exposure are irritation, burning of nose and throat, irritation of mucous membranes, burning skin, coughing, and vomiting. Formaldehyde control, localized ventilation, negative pressure. Containers of formaldehyde and formalin should be tightly sealed. Latex gloves should be avoided. Suitable PPE, rubber gloves, face shields or safety goggles, and aprons. Glutaraldehyde is disinfectant, primarily for endoscopes. Risk of exposure at endoscopic units, operating rooms, ICU, and dialysis wards. Exposure by inhalation and skin. It will lead to asthma, rhinitis, contact dermatitis, wheezing, nose bleed, and headache due to upper respiratory tract irritation. Control of glutaraldehyde, fully automated and enclosed disinfecting machines, PPE for handling glutaraldehyde, safety goggles, and previous aprons, and nitrile or rubber gloves. Mercury, latex gloves do not protect against many forms of mercury as elemental mercury. Double disposable nitrile gloves will protect. Methyl methacrylate and other bonding materials, dental and surgical Siemens, exposure, breathing vapors of liquid form. Acute health effects, irritation of eyes and upper respiratory tract will lead to sore throat and cough. Prolonged exposure will lead to asthma, hypersensitivity, pneumonitis. Overexposure to MMA will lead to decreased appetite and sleeplessness. Skin contact will lead to itching, burning, redness, swelling, and cracking. MMA easily penetrates surgical gloves. MMA hazard control, operating rooms and dental lab for preparation of bone cement and dental composite, equipped with vacuum exhaust, mixing bowls or negative pressure hoods, gloves, goggles, or face shield. Hazardous drugs for healthcare workers, aerosolized medication, anesthetic gases, antineoplastic, nitric oxide, pentamidine, and ribavirin. Here we will describe aerosolized medications. as beta agonist, anticholinergic, mucolytics, antibiotics, morphine, and ergotamine. Examples of side effects: stimulation of CNS, blood vessel constriction, and decreased immunity, decreased pulmonary function tests, and acute respiratory symptoms, development of drug-resistant strains, controlled decreased healthcare worker exposure, decreased loss of drug during administration and or exhalation, and decreased environmental release through a filter. Anesthetic gases as nitrous oxide combined with isoflurane. We described before. Antineoplastic drugs may lead to carcinogenicity, teratogenicity, reproductive toxicity, organ toxicity at low doses, and genotoxicity. Exposure during preparation control. Prepare in a fully enclosed box. Biosafety. Allergy to secretions of lab animal due to respiratory inhalation of sensitizing proteins and through dermal contact affect 30% of those work in these places. Zoonotic infections are occupational hazard, so occupational physicians must determine employees at risk for infections as rabies, salmonella, and ringworm. Other exposures include percutaneous exposure to biologic agents, radioactive isotopes, carcinogens, chemicals, anesthetics, and drugs. Prevention of occupational hazards in lab. Medical monitoring and surveillance programs should be developed in areas of reproductive hazards, hearing conservation, respiratory protection, immunization, blood-borne pathogens exposure, zoonosis, emergency medical response, physical and environmental hazards. Occupational radiation in healthcare facilities, ionizing radiation or non-ionizing radiation. We described them fully in the lecture about radiation. Ionizing radiation can lead to cancer as leukemia, stomach, liver, colon, lung, breast, uterine, and thyroid cancers, and genetic effects. Control by time, distance, and shielding, environmental and personal monitoring by film badge, thermolucent dosimeters. These were described in the lecture about radiation. Here is a picture of a technician using Geiger counter to assure that after inpatient therapy procedure there is no contamination by radiation. Maximum permissible dose limits for ionizing radiation. Here is described. Please print it and use it in your hospital, and it was described before in the radiation lecture. Non-ionizing radiation, extremely low frequency or very low frequency. These are non-ionizing radiation exposure from various types of medical equipment present in any hospital, and who will be exposed to it. The equipments are MRI, magnet and gradient fields, radio frequency coils, microwave diathermy, shortwave diathermy, electrosurgery units. Here is the ergonomic hazards, exposure hazards at computer workstations, handheld devices, laboratory, laparoscopy, patient handling, radiology, slips and trips and falls, sonography. Ergonomic exposure due to use of excessive force, as in lifting, pushing, or pulling. Awkward, constrained posture, as bending, twisting, repetitive motion, and vibration. Some symptoms of ergonomic illnesses are fatigue, soreness, aching, burning sensations, muscle or tendon pain with or without movement, joint pain, reduced range of joint motion, numbness, tingling, low back pain or sciatica, venous insufficiency. Slippery floors, trip hazards will lead to falls, which will lead to injuries to multiple body parts. Here is another part where ergonomics must be organized in very good place inside the hospital. This for computer use, hands and wrists for arms, head, shoulders, elbows, feet, back, thighs and hips, and feet and knees. Please print it and use it while working or one of your colleagues working on a computer. The hands, wrists and arms must be straight, in line and parallel to floor. Head is level or bent slightly forward facing and balanced in line with torso. Shoulders relaxed and upper arms hang normally at side of body. They must be rest on the rest of the seating. Elbows close to body and bent 90 to 120 degrees. Feet supported by floor and rest. Back supported with lumbar support when sitting. Thighs and hips supported by well padded seat and parallel to floor. Knees are same height and as hips. Feet slightly. Social and administrative hazards, shift work, stress and violence. Definition: shift work is work scheduled either permanently or frequently outside normal daytime working hours, 7 a.m. to 6 p.m. Long work hours, 50 hours or more per week, or shifts longer than 8 hours, in particular 12 hours. Major health effects of shift work on GIT, cardiovascular disease, CNS, reproduction, and decrease disease. Gastrointestinal disturbance, a change in sequence of time of meals. This will lead to these disturbances. Stomach cannot cope with composition and quantity of a typical daytime meal. GIT complaints or even disorders. Peptic ulcers were twice as frequent among former shift workers as among day workers, with a subsequent significant decrease in GIT disease after transfer out of the shift work. CVD disorders. Studies on evidence of CVDs in shift workers yield increase in CVDs, about 40%, particularly among those who were transferred away from shift work. Reproductive outcome. Shift work associated with a modest increase in spontaneous abortion, preterm birth, and reduced fertility among women. Exacerbated diseases. Unstable angina or myocardial infarction, hypertension, insulin-dependent diabetes, asthma, psychiatric illness, alcohol or drug abuse, epilepsy, GIT diseases, sleep disorders, chronic renal impairment, thyroid and suprarenal disease. Occupational health measures to control hazards of shift. Workers should be counseled against night work if they have the following: insulin-dependent diabetes mellitus, thyrotoxicosis, coronary heart disease, epileptics, narcoleptics, sleep disturbance, severe psychiatric disorders, chronic depression, asthma requiring medication, alcoholics and drug addicts, marked visual impairment, a history of digestive tract disorders, active and extensive tuberculosis. Psychological and neurological disorders in healthcare workers. There is a greater tendency toward general malaise, including anxiety and depression in shift workers than in day working colleagues. And the hospitals and healthcare facilities have many shift workers. Occupational stress. Physical stress, symptoms of stress, physical symptoms of stress: headache, insomnia, dizziness, blurred vision, trouble in swallowing, aching neck or shoulders, backache, asthma, chest pains, excessive sweating, high blood pressure, indigestion, ulcers, sexual difficulties, others as diabetes and skin. Psychological symptoms of stress: difficulty in concentrating, lack of self-worth, more pessimistic and unhappy, increased anxiety, feeling tense and strained, irritability, indecision, absenteeism. Social changes: increased use among stress, increased use of stimulants, alcohol, foods and drugs. Stress management: physical exercise, balanced diet, controlling time, getting help from others, leave drugs, giving help to others, redesign your work, communicate properly, manage change. وفي النهاية أقول الحمد لله thank you for your good listening and I would like to accept any questions.